Hello, everyone. I'm Dr. Renee Mehrra. Thank you for joining Zoom in with Renee. Today, my guest is Dr. Bobby Mukkamala. He is the immediate past chair of the American Medical Association Board of Trustees. He's an otolaryngologist, head and neck surgeon practicing in Flint, Michigan. Thank you so much for joining.
Absolutely. No, very glad to be here. Thanks for having me.
Thank you. Now, you bring in a wealth of experience and deep insights as the immediate past chair of the American Medical Association Board of Trustees. I want to tell our viewers that Dr. Bobby Mukkamala is the first South Asian to hold this coveted position. So share some of the initiatives that you brought in your role as an AMA board chair.
Yeah, just to clarify a little bit about how the AMA is structured. So the policy of the AMA, the things that physicians across the country ask the AMA to do, is created by our House of Delegates. And so the initiatives that the AMA goes to take on come from the House of Delegates. The purpose of the Board of Trustees is to manage that work between when the House creates that policy and when the AMA executes that policy. So, for example, when an opportunity comes, as it just did to me today, to talk to the ONDCP, the Office of National Drug Control Policy, about opioid prescribing and managing substance use disorder, then the AMA dispatches me as the chair of that group within the AMA to go talk to the ONDCP about this based on policy that the House creates. And so as far as my own fingerprint, if you will, on the AMA's work, I would say that my passions are in two places. One of them is what I just mentioned, substance use disorder and pain care, to make sure that in our response as a country to a record number of overdose-related deaths, that we also maintain the ability to take care of our patients that are experiencing pain. So trying to kind of walk that line and find that balance between preventing unnecessary deaths from substance use disorder, but also taking care of patients with pain. That's a passion of mine and why I chair that committee. Another aspect, I think, comes from my own history. So my presence right here in Flint, Michigan, is because of my parents immigrating to this country as physicians and doing their training at Hurley Hospital, which is literally about 1 mile in that direction. And the fact that in 1970, when they came, this country was so in need of their services, just like so many other international medical graduates, that it welcomed my parents with open arms, with a contract that was basically done via the mail from India to Flint. And then here we are now in a country that has a workforce that is, 20% IMGs, a large percentage of which are from India. And I think it's a different feel that I think we're experiencing now, as far as that welcoming and the ability of an Indian American physician or an international medical graduate to thrive in this country. The fact that when IMGs come now, they're waiting sometimes for 20 years to get green card status. Right. And they're sort of in odd employment relationships and things like that, in limbo, waiting for that. So that's another thing that motivates me to work on behalf of the American Medical Association, just to improve these things that we notice on a day-to-day basis. And Lord knows that there are enough things that need improvement within healthcare, that the AMA is an organization that's equipped to fix these things as they come up.
Yeah, these are great initiatives, and I applaud you on that, especially opioid overdose. We see that all the time. Has your background as an Indian American, has it shaped your vision as a physician and in your role in the AMA board?
Yeah, I think so. I think that, when I think back on, where my parents were raised in Andhra Pradesh in India, and then to come here and make a life for themselves in this country in the 1970s when they immigrated, I feel like for me as a physician, to do what they did, which is to take care of the community, is great. But I feel that there's also a calling to do more than just practice medicine, right? That I feel like I owe it to this country that embraced my parents to do more to improve medicine and healthcare as a whole, instead of just delivering that care to my patients. So the policy side of things. And so I think that as an Indian American physician, as a second generation physician in this country, that in addition to practicing medicine and taking care of the otolaryngology needs, in my specific case of my community, that there's a responsibility to improve healthcare, to leave it better than we found it. And I think that's what motivated me to get involved with the American Medical Association, which is the vehicle that I chose to use to improve healthcare.
Let's talk about the AMA work that's on Capitol Hill, lobbying for health equity. We're also talking about AMA's recovery plan for physicians, especially when you're looking at physician burnout or Medicare longevity or supporting telehealth or prior authorization. These are very critical issues that come in the arena of healthcare. And so share some of the work that's been done.
Sure. Yep. As you know, something as complicated as healthcare in this country, with the amount that we spend as a country on healthcare, there's obviously going to be lots of components of the delivery of that care that need attention. And we work on so many of those. The policy that House of Delegates that I described is pages and pages of policy that's been created over the years. But in any given year, we have to focus our attention on those things that are of highest priority. And so what we've decided recently is that those things that are highest priority are some of those things that you mentioned. So, for example, reducing physician burnout, something that is near and dear to your heart, I know, and to my heart, the fact that we need to continue to prepare physicians to face this constant, never-ending onslaught of difficulty doing what we know to be the right thing, whether that's things like prior authorization, whether that's things like scope of practice, mutation and change so that it's no longer physicians involved in their own patient's care. These are just two examples of things that lead to physician burnout. And I think that there's two ways to address that. And I'm sure we'll talk about it more, is one, addressing the cause of the burnout, right? If it is something like a payment decrease that's making it hard for us to do our job in the face of ever increasing costs to practice, that's something that deserves attention. But there are some things that are going to be harder to fix, right? That are going to take years to fix, if not decades to fix. And for that, we need to improve our own resiliency as physicians to deal with the headwind of practicing medicine. Other priorities that the AMA has is, I mentioned the scope of practice, right? We want physician-led care teams to take care of our patients. We have lots of data to show that when physicians aren't involved in patient care, the costs go up and quality goes down. And that's the wrong direction to go in as a country. Another aspect is prior authorization. It boggles my mind that for every one of the million physicians in this country, there is 1.4 FTEs, so essentially 1.4 million people just working on prior authorization. Just an incredible waste of human resources and capital to take care of our patients when 90% of those prior authorization requests are approved. And so that's something that we want to right size. Use it when it's useful. If there's a pharmaceutical treatment for our patient that's going to cost $100,000, sure, prior authorization for that is reasonable. But if it's a CT scan of the sinus that costs $200 that gets approved 100% of the time, to have 1.4 FTEs working on that sort of prior authorization doesn't make any sense. And then, another important one, especially this time of year when the budget is just now starting for a new year, is the Medicare payment, right? The fact that when our costs have gone up so much related to COVID and we have so much increased administrative and overhead costs just to take care of our patients, that in that moment to have a 2% reduction in Medicare payment just seems so wrong, right? The fact that hospital payments and insurance company related costs and management have continued to go up under Medicare, but physician payment has stayed at a single digit increase over the course of 20 years is something that needs to be addressed. And then finally, I think something else that I should talk about is the role of telemedicine, right? This new evolution of telemedicine to take care of our patients and the role going forward. So just some examples of what we're prioritizing now.
Yeah, I'm going to talk about telehealth in just a minute, but I wanted to talk about, you did touch upon that, we spend astronomical amounts on healthcare, but we do not get the same positive outcomes that we should be getting, especially when we're looking in the area of mismanaged diabetes or life expectancy or infant mortality. Do you agree with me that we need to disseminate more aggressively community education, especially to marginalized, vulnerable communities, have more upstream interventions, regular pre-screening, early detection is the key. So what are we doing in this area?
Yep, no, 100% agree. We don't want to be taking care of the diabetic foot ulcer at this end of that spectrum of time, right? We want to be taking care of the pre-diabetic before they even get diabetes, before they even develop that diabetic ulcer. That's where our investment of time needs to be. And that's exactly what we're prioritizing within the American Medical Association to address those things on two main drivers of this chronic disease. One is hypertension and one is prediabetes, right? So exactly what you were mentioning, because right now the system, it doesn't incentivize the prevention of disease like it should, right? Instead, what it does is just pays for the consequences of that disease. We need to change that mindset and make our country aware, make our administrators, our politicians, our lawmakers, and our patients aware that time spent preventing disease is much more beneficial than time spent managing the downstream outcomes of that disease when frankly, that horse has gotten out of the barn already. So absolutely, I agree that that's where we need to put our attention. And that's why the AMA has made large investments over the course of the past 5 to 8 years in exactly those two particular aspects of chronic disease, prediabetes and hypertension.
I think that's where I think lifestyle medicine plays a very big role over here in public health. We're talking about proper eating habits, exercise, right sleep. All this comes in lifestyle medicine, holistic medicine, prevention, so very important. Get the root cause, not just address the symptoms. And I'm happy that you are talking about that.
What we can take care of in that 15 to 30 minute encounter in our office compared to what can be taken care of before the patient even arrives in our office because of attention to things like access to healthy food, access to places to safely exercise and have recreation without having to worry about, like you said, the populations that are most at risk of poor access to healthy food and lack of access to areas to exercise and have recreation are the ones that are seeing the consequences of the burden of that chronic disease. And so to focus attention, not just within the walls of our exam rooms and operating rooms and hospitals and healthcare structures, but in our communities, that's where that investment will then pay off by decreasing the cost over here.
Absolutely. And when we look at mental health, with COVID, the pandemic really accelerated many mental health issues. And here again, we're talking about prevention, early detection, destigmatizing mental illnesses, especially in South Asian communities. We don't talk about it, yet it is very important to bring it out in the open, that we can do a lot in this area. I know that you had organized a mindful health summit in Michigan, and Dr. Deepak Chopra was one of the speakers out there. Mindfulness, meditation, they can become an adjunct therapy in clinical practice and still the mind, get feelings of more groundedness and being more balanced. These are very important components when we're looking at optimal wellness of the body, mind, and spirit.
Mm-hmm. Yep, no, absolutely, and you're 100% right that we need to pay more attention to that. There are some things that are obviously mental health related, right? Like substance use disorder, for example. The work that I mentioned that we do on our task force is just one component of the things that can happen to our bodies because of mental health related issues. And there is just such a lack of proper attention to those things, right? Just clinically speaking, the fact that if I needed a knee replacement or a hip replacement or something like that, it would take me less than a day to find somebody to see that was willing to give me an appointment, that was willing to take me to the operating room to fix that problem, right? Like that's something that can easily be solved. But if I had a mental health issue, right, here in Flint, Michigan, if I have a substance use disorder and need some therapy for that, I would be spending weeks trying to be linked with that therapy. And God forbid I need inpatient care for that problem. I'd be waiting even longer than that to find placement because of a lack of resources. So what we're prioritizing within the system needs to be balanced. We have a theoretical solution to that problem, what we call mental health parity, right? Where we say to those people that are paying for the cost of healthcare that they need to pay for mental health in the same way with parity as they pay for more traditional sort of healthcare. And to have that in name only, but not actually have that in practicality, like not have inpatient beds to deal with mental health issues is a problem. And so this is the kind of thing that we're advocating for. And as you mentioned, even beyond the acute nature of healthcare crises associated with mental health, preserving mental health, sort of working on that mind-body connection and just improving awareness is what we've been working on here in the Flint community. As you mentioned, we did have Dr. Chopra come in to sort of lead that work for us and sort of give the inaugural lecture in a series of work that we're doing. And we've had John Kabat-Zinn, another sort of pioneer in mindfulness as it relates to improving health, come in as well to help drive that work. And I'm proud to say that Flint is on the cutting edge. A community that's been so distraught in the post-industrial economic decline, for a community like ours to be on the cutting edge where every classroom in Flint community schools, in Flint public schools, engages in mindfulness activity on a daily basis to help orient the students to the task at hand, which is coming to school, sort of leaving what they came from as far as their home life, in somewhere else so they can focus on the classroom. That is amazing to think that happens in every school in this Flint community. But it's so important that it happens. And we're getting a lot of attention for that because there's a lot of other school districts interested, but not just school districts. Even employers are seeing the benefit of better mental health, mindfulness as a way to get to a better state of mind for their employees to improve their productivity and improve the climate in the workplace. And so, whether that's the hospital system, whether that's a factory that has hundreds of people working in it, or whether it's Flint Community Schools, mindfulness is being seen as a tool that will improve the productivity of the workforce and the productivity of the student.
Yeah, absolutely. And I think being in the moment and being mindful of what we are doing, it really grounds us, balances us. And then I always say, take it to the next level with taking the journey within, inwards and upwards. Mm-hmm. Do you feel that telehealth, especially in the area of mental health, is less costly? And a lot of times we feel that this hybrid model, sometimes going to the doctor's office and sometimes with telemedicine, we're able to get a better outcome for our patients.
Yep, I think it has a critical role to play, and I think we saw that during COVID, right? That right there was an example of where we saw sort of a peak in telehealth activity. The ability to take care of our patients remotely came in so handy during that time where our offices were closed pretty much. And now that we see the value, and I think that's evolved to show that there is an ongoing role for telemedicine and telehealth to play in the care of our patients. My wife, who's an OBGYN, realized during this that, her well women visits for the women that are postmenopausal that don't necessarily need to be coming into the office, but just need some labs gone over and just, the history taking and some advice on the symptoms that they're having is something that is just perfect for the role of telehealth. So she's adopted that. And I think that's something that she's going to continue going forward. And as we mentioned, things like mental health or the care of patients with substance use disorder, that's less physical exam intensive, but is more about taking a history and then counseling patients on what our advice is to help to manage those conditions, is perfect for telehealth to play a role in, right? Or to have a primary role in. On the other hand, my day job, which is to look in people's ears and make diagnoses of what's going on in their tympanic membrane, or, taking something out of their nose, or that sort of procedural, physical exam intensive, is not as appropriate for telemedicine. And so I think this is kind of what we are seeing evolve, is where does it fit well? And let's preserve the ability to be compensated for that care. And where doesn't it fit well? And also, who's doing it, right? So, doing it remotely or via telemedicine is something that may be done well in certain hands with certain training and not with other training. And so just making sure that the person that's doing it is the best person to do it, and making sure that the compensation is available for that, for the convenience of the patient, because we all know how hard it is to take an entire morning off work to go sit in a doctor's office for an hour for a 15-minute appointment, versus knowing that we can click and we can be on screen with them, just like you and I are on here, to deal with that without the disturbance to our work schedule. So for all of those reasons, it is something that needs to stay. And the most important part of that, the change during COVID and needs to stick, is the ability to be compensated for providing that care, because that wasn't there before COVID.
That's right. Now, you have been very active in the Michigan State Medical Society Board of Directors, and worked very extensively in providing a lot of education and lead leaching and drinking water in Flint, Michigan, your hometown. share some of those experiences that you've had? I know you have the foundation to bring more awareness on this issue.
Yeah, yep. So this is something that was an unfortunate chapter in the history of my community. A community that, as we already mentioned, sort of suffered the post-industrial sort of decline economically, and then the big recession that we had in the early 2000s, and then on top of all of that, right in the middle of trying to revitalize the downtown area and bring more businesses in and sort of lift this community back up after a half a century of decline. Then all of a sudden we find out that kids that are coming in for routine screening have elevated lead levels because of a lack of proper treatment of water during a switch from one water supply to another. And so this is already a population of kids that we've already talked about has so much adversity, whether that's lack of access to healthy foods, lack of places for recreation, lack of a family structure that will be supportive of them, lack of safety in their own communities. On top of all of that, to have a lack of safe drinking water was just devastating, right? And so that's something that we've been working on through, as you mentioned, the local community foundation. That sort of the country and the world was very generous to Flint in that time to help us get through that. And so making sure that those kids that were maybe in utero at the time of exposure, to make sure that they have the resources to sort of get access to healthy foods and education to the point that they're 18 is something that, even though this is no longer in the headlines, those kids are still suffering from the consequences of being worried about every time they turn on the tap to get a glass of water or to use something to cook food with. That crisis of confidence and the consequence to their biology, even because of that exposure to a hazardous element, is something that needs continued attention. So even though it's not in the headlines anymore, we have a role to play to making sure that those kids continue to have access to what they need to end up as productive adults in this community. And that's what this foundation is meant to do.
And I think our children need to be aware of these issues even when they become young adults. Mm-hmm. Now, your father was the president of the American Association of Physicians of Indian Origin, that's API, in the 80s. Do you see a closer ties of the American Medical Association with API? Because many of their issues are pretty much converge with the AMA. And we're talking about health equity or physician burnout. Do you see that bond?
Yes, yep, for sure. I see it, and I see it growing, right? The communication, the fact that just this week I was invited to the API Young Physician Section meeting that's going to be happening next month, that we have a presence at those meetings now. We, meaning, my perspective from the American Medical Association, for the AMA to work closely with API, which represents Indian physicians, which, as we mentioned, is a huge percentage of a large number of international medical graduates in this country, or people of Indian descent, is going to be a critical link in collaboration going forward, especially because so many physicians that did immigrate here to practice medicine are providing that care in those communities that need it the most. Right. My parents came to Flint, Michigan, because it was a community in need, and it was a community that welcomed them to help support the delivery of care in this community. And so, because we are taking care of patients in these communities, it's important that we, as Indian physicians, people that are represented by API, benefit from the work product of a group like the American Medical Association that has so much to offer as far as management of chronic disease and fixing some of those problems that the underserved in our communities have. So it's a natural sort of bond between a group like API and a group like the AMA, because our goals are so in line.
Absolutely. Lastly, Dr. Mukkamala, what do you envision healthcare in the United States when we compare it to other developed countries? And we're looking at a lot of physician shortage here in this country right now.
Mm-hmm. Yeah, no, I think it's a very turbulent time for healthcare, whether that's replacement of physicians with non-physicians, whether that's the influence of, something new that we're seeing now, the role of private equity in owning a large percentage of physicians' practices, if not being the majority owner. These are all things that we have yet to see what that's going to lead to. Is it an evolution, right? Is it an improvement, or is it a devolution? Is it going to take us in the wrong direction? And so I think there's a lot of uncertainty now, and that uncertainty is driving it's further fueling the physician shortage, because it's people that are 55 that might be maybe intended to retire in 10 years will say, you know what, I'm just going to do this for another 5 years, and then I'm going to go do something else. And so that is going to affect our ability to take care of patients. So I would like to say that I'm confident that the skies are bright and we're heading in the right direction. But honestly, the skies, I think, are cloudy, and there's a lot of things that will require our attention, which I think is important then to have conversations like this, to point those things out and to motivate people to be participants in the solution to those problems, as opposed to trying to escape those problems.
Where do you see yourself in the next 10 years?
So it's an interesting question. So my time at the AMA in leadership will long since be over in the next 10 years.
Yes.
Probably in the next 5 years. And so I actually, just last week, I went to Flint community schools to observe in kindergarten and first grade and fourth grade, because I'm planning on getting my teaching degree, what's called an alternate path to teaching. And I hope to teach high school math and science here in my Flint community. In the mornings, I'll be cleaning out earwax and picking people's noses in my office. And then in the afternoons, I'll be telling kids about the science of boogers and earwax. So quasi-doctor and quasi-teacher is what I hope to do in about 10 years.
Well, thank you very much, Dr. Bobby Mukkamala, immediate past chair of the American Medical Association, otolaryngologist in Flint, Michigan. Thank you for your time, and wish you all the very best in your endeavors.
Thank you very much. It was an honor to be here with you.
Thank you. And I'm Dr. Renee Mehrra. Thank you for watching. Stay healthy, stay positive.